let us now move on to the final discussion for today. In the realm of reproductive medicine, the advent of pre-implantation genetic testing has ushered in a new era of precision and empowerment for prospective parents. By offering insights into the genetic health of embryos prior to implantation, PGT holds the promise of reducing the risk of inherited genetic disorders and improving the success rates of assisted reproductive technologies. Paired with comprehensive genetic counseling, PGT empowers individuals and couples to make informed decisions about family planning, ensuring the birth of healthier offspring. And with this, let me introduce you all to the topic of our final panel: pre-implantation genetic testing and counseling for better outcomes. Now, I'd like to welcome our panelists to join us on stage. Please welcome them with a huge round of applause. Dr. Gauri Agarwal, founder, Seeds of Innocence, IVF Chain and Gene String Lab Center. Dr. Amit Bhatnagar, Vice President, Asia Pacific Fertility Solutions, Cooper Surgical. Dr. Beena Muktesh, Clinical Director and IVF Consultant, Motherhood Hospital. Dr. Ashish Fauzdar, Clinical Genomics Head, Redcliffe Labs. Dr. Shweta Mittal Gupta, Co-Director and Senior Consultant, Center of IVF and Human Reproduction, Sir Gangaram Hospital. Now, I request Dr. Shweta Mittal Gupta to please take over this session from here.
Thank you very much. Thank you very much, and good evening, everyone. We've come to the end of the session. I've been hearing a couple of very interesting, discussions and panels from NGS platforms to precision medicine and neurology, and let's see if we can do some justification when it comes to precision medicine in reproductive medicine. So I think we'll kind of start with a very basic question, that we know that when a baby is abnormal, we have certain tests during pregnancies to offer. If there is a known genetic problem, we can do a chorion villus sampling or an amniocentesis. But is there anything which we can offer before the patient is pregnant? So I think I'll start with Dr. Gauri, that what can we offer?
So there's something which I think we all should start with is today, preconceptional counseling. I think that is the most important part, because I think most of the couples in this era today actually plan a pregnancy, and preconceptional counseling is a very important part. And there is a specific test known as carrier genetic testing, which can actually tell whether you have any genes or any disorder chromosomal which runs in you or your family, which can be picked up before you get pregnant. Once we are doing an IVF, there are certain tests known as PGT-A, PGT-M, which gonna screen the embryos for genetic testing. And in this, you can screen your embryos to know which embryo is actually euploid or aneuploid. So what is the difference between a euploid and an aneuploid is? A euploid embryo is chromosomally healthy. It's a genetically healthy embryo. Aneuploid is when there is some chromosomal defect. There's one more criteria in this, where there is a mosaic embryo, where there is a mixture of normal and abnormal chromosomes. So we have to be very, very careful as a clinician while counseling the patients for these mosaic embryos. And thirdly, during pregnancy, as ma'am has said, we have amniocentesis, we have chorionic villus sampling, we also have non-invasive prenatal testing, and after birth, we have newborn screening. So this is a complete, portfolio for reproductive genetics today. And it is like very, very helpful as a clinician and as an IVF specialist that we should use all of them as and when required.
Yeah, so very comprehensively, summarized. So we have, since our panel is on pre-implantation genetic testing, so we have PGT-A, which will just, look at the numerical abnormalities. We have PGT-SR, which will be looking at the structural problems causing most of the times miscarriages. or some congenital abnormalities. And then we have PGTM, where if there are known, disorders like thalassemia, sickle cell, any kind of these disorders, so it can be helpful in eliminating the disease from the family by taking out these disorders. So, Dr. Beena, if you have to choose a process, let's say PGTA, then whom do you think are the most eligible, women or couple whom you would be advising?
Yeah, thank you, Dr. Shweta. Generally, in PGTA, we take care of all the people who are having repeated abortions because of some genetic problems, and we do not come to know. So we just come find out, is there any problem in the chromosome, so that they are having a repeated abortions. Moreover, when patients are at advancing age, then also most of the time the genes, the pattern is like they have abnormal embryos, and at that time also we need to know which embryo we should implant so she has a normal pregnancy without any genetic problem. So as we know that as the age advances, the abnormalities increase. So that is called aneuploidy screening, in which we see aneuploidy and euploid embryos and find out which are the best embryos to be implanted.
So, Dr. Ashish, it's easy. We earlier setting up an IVF lab was easy. Now we have lots of rules. ART, rules have come in place. We need to register as, a level 2 ART clinic. But to set up a PGT program, what is something further that we would be needing?
So, Government of India has recently rolled out a act which is ART guidelines 2020, and as per this, no IVF clinic can offer PGT services unless until they are registered with government. So there are certain forms, Form 1, and I come across a clinic who have a patient for a PGTA, but unfortunately they could not check the box where they have to register with the government, and they could not offer that service. So now in today's scenario, PGTA offering to a patient through any IVF clinic unregistered is practically difficult, and there are now strict laws, and then there could be consequences if they are not registered.
I think Dr. Beena wants to add.
Yeah, actually, we just need to know, like when we are taking sample, we need to send it to the lab. So the lab need to be registered as taking out the genetics testing, while other clinics can take the sample and send it to the lab.
And they also need to be
they
registered
need to be
as
registered.
a genetic clinic, because the moment you're doing an invasive biopsy, then you become liable, because in India we have the PCPNDT Act where disclosure of gender is prohibited and illegal. So we need. So, yeah, Dr. Gauri
So,
wanted to add.
actually, there's one more point in this is that all IVF clinics who register for their ultrasound have to get themselves registered as genetic clinic, not just as genetic counseling center. So even if you're using a laser biopsy at your center, you have to have a genetic clinic registration, and you need to counsel the patient only at genetic clinics.
Yes, absolutely.
And then second thing is all the genetic labs have to give this data to PCPNDT every month. For NIPT and for PGTA, like all ultrasound reports, you have to submit the data to the government because they require as a rule for PCPNDT.
And in the end, you will have to give all your delivery data and the sex ratio too of your lab, which is very important. Now, Dr. Amit, since you have a large platform to offer, so we are clinicians. So how do you convince us that what platform is best when it comes to PGT testing? How has PGT evolved, and now we are at this level where we can say, okay, we are in the precision medicine.
So I'll go back to and I just want to add, IVF is going through the same way the diagnostic lab, our diagnostics have progressed in this country. So PCR pre-COVID, PCR post-COVID, you look at it, has become commodity. There are gold standards in all the I would say field in healthcare. Microbiology, you have culture as a gold standard. In molecular biology, PCR has become gold standard. In IVF genetics, we have FISH, we have IS. Those are like gold standards, right? So, and then you have something which has come up is NGS, correct? So it's a technology. And to provide that kind of technology, you have different vendors coming up and convincing clinician and the labs, this platform is superior and all those things. So what is the most important as of now for a patient is basically looking into the like personalized thinking process. So which technology to use and what kind of technology is going to give you the like next level of advancement. That is the most important. Another thing is very important in this IVF genetics is to think about that should I have a lab? And as all of you have said that there are rules and regulations which are going to be very, very stringent in this country. So it has to be consolidated approach, which we all need to think about in IVF genetics, because we will not have the like too much of sample pools, because technology is evolving so fast. And the labs who are going to be consolidated, offering this kind of like testing to the clinician, they need to really think about that. We need to send sample outside. Until unless you don't have the like sample load, your sequencer or any technology is not going to work around. So you have various technologies available in your lab, which can be like gold standard of the like past, and then you have the newer technology like NGS, which has come out. So thinking in those direction that how my patient is going to be benefited, that is the most important. So patient centric has to be there. Now another advancement which is going to happen is the AI. So whatever we are going to talk about in the IVF.
We will sum up with
Yes,
that.
okay.
So I remember that in Gangaram Hospital 20 years back, we were doing FISH. Then it was only detecting the 5 chromosomes. Then we went to array CGH technology, and now we are in the NGS platform. So Dr. Ashish, is your lab also offering NGS when it comes to PGT?
So, like as you have mentioned, PGS has advanced in last 20 years. It all started from 1990 with the FISH technology for X-linked disorders, and then it shifted to array CGH, and lab also gradually upgraded themselves, and now NGS is the time where we are offering next generation sequencing based tests based on different platforms which are available. And this is so one should be remembering, so every platform has its limitations. Initially we were screening couple of chromosomes, 5 chromosomes, 11 chromosomes, then array CGH. So there was a problem with mosaicism. So NGS have over a period of time have overcome all these limitations, and it has become a standard care now. And now NIPS, non-invasive and invasive PGS techniques are now coming forward. But we'll discuss on NIPGS because a lot of concordance issues are there. It is still under validation phase. And so NGS is definitely now routine testing as of now. For
Since we run a in-house NGS lab with our IVF centers, I feel it's a blessing for the patients because we have loads of patients who I feel require PGTA testing. I mean, it's criminal also at times when the patient comes at 35 years of age or maybe low sperm count, or patients coming with 2 or 3 abortions, recurrent abortions, or patients coming with 2 IVF failure. We just tell them that you go ahead with donor eggs because there is no other option. So almost my 50% of the couples are counseled for PGTA, and since they have recurrent abortions, why should we at 27 or 28 years of age, that couple comes and says, I had 2 abortions and they had blighted ovum, and why should I tell them to go for a donor? I mean, it's so simple. She has good pool of eggs. Just take out her eggs, use the sperms, go ahead with the PGTA testing, because 50% of the reason for an abortion is genetics. So why donor?
So yes, I agree. If there is a known genetic cause for miscarriages, then yes, offering PGT-SR is a very, very sensible and safe option. I have Dr. Ratnapuri sitting here. Hello. So she always, the patient will come to us after counseling from her, and we will see that one option is still you can go ahead with your own conception. What is the chance of getting? But what Dr. Gauri just said, multiple miscarriages, known genetic cause, yes, offer them PGT-SR.
So I want to discuss a very beautiful case. That patient got pregnant. So I had this couple, first child, they have abnormal girl. She cannot walk, she cannot eat, and she's on bed. Second, they had a IUD that the baby died inside the womb. 2 abortions after that. So once they had an abortion, they got the genetic testing and they realized that the father has balanced translocation. And now this couple comes to me with the fact that I want to have a healthy pregnancy. And this is how where genetics comes and plays a very, very important role. So we counsel them, we took out their eggs, their sperms, we did PGT-SR for balanced translocation, and today she's 12 weeks pregnant. I mean, that is what IVF means. IVF is just not about taking out eggs and sperms, it's much more complex today. So, I mean, without genetics, IVF, I don't think so. It's very, very, it's not justice to do IVF without genetics today.
Yes, absolutely.
Maybe coming years they will only transfer embryos with after doing PGTS.
Dr. Meena, do you have some case, to discuss? Like how she said the husband was a carrier of balanced translocation and could be offered, PGT, SR, and
Many patients are coming with such kinds of thing who have a single gene disorders or any other disorders. They go, the laboratory goes till the parents and siblings, and even they make a probe for that particular genes, and then they find out and tell us the possibility of what is the possibility of having a normal child and what are the good embryos to be transferred. So
I
like
can-
that, there are many cases which I cannot pinpoint point one, but every day in and day out we are seeing such cases.
So I recall one case out of multiple cases where both the husband and wife were carriers of thalassemia with one baby affected. Now they not only wanted IVF, not only wanted a PGT-M, but they also wanted an HLA typing. Little ethical issues, but still allowed in India. They went ahead, got an embryo which was 10 on 10 match, and now the baby is born and they've gone ahead and done bone marrow transplantation so as to treat the first child. So there are expanded indications and ways where IVF can not only help infertile couples but also people with diseases or multiple miscarriages. Now, Dr. Ashish, you were talking about mosaicism. So we very easily, it's easy to say that this is a lab, I'm performing well, let's do and set up a PGT program. So I want to know from Dr. Ashish and Dr. Amit, what are the nuances, what are the problems we face?
So, mosaicism is a condition when an embryo inherit two kind of cell line, and this is very common in pre-implantation embryos. And as you know, 20 to 80% of the time, these embryos are chromosomally abnormal, and we have seen a lot of patients coming back to us for counseling and even for further discussion. Now we have got a mosaic embryo, what should be done, whether it has to be transferred or not. So definitely there are guidelines, there are certain group of chromosomes where there is a absolutely no, where there should not be a chromosome transfers, like chromosome 13, 18, 21, sex chromosomes. So if these chromosome abnormalities are there in those embryos, it is absolutely no. But I would like to bring your attention to the live birth rate in mosaic. So it is less than 0.2%. So if we see only 0.2% of the embryos, if they happen to complete the pregnancy, the live birth rate is 0.2%, which means there is a correction of embryos happening during the course of pregnancy. So, but there has to be a proper counseling to these patients, and all this should be left to the couple to decide whether they have to do a embryo transfer or not. So mosaicism is really a confusion, and if there is a proper genetic counseling, a couple can take a informed decision, and we can share the facts and science before the couple so that they can take a wise decision.
So there have been situations where all the three embryos came low mosaic, and then we took genetic counseling from the genetic department, that which is the sequence in which is a big no, that no, this embryo should not be transferred, and which can be transferred in the sequence. So Dr. Amit wanted to.
So Dr. Shweta, I think I will go back and I'll go to the basics. Mosaic disorders and all those things is like when we are testing the embryo and we have the results coming out. But before that, the limitation for having a genetic testing is basically, do we have a qualified people? That's number one. In our country right now, we are struggling to get a right biopsy. So what is the basis of doing genetic testing is basically the sample. So are we having the enough skilled manpower in this country to do those biopsies? That's very, very important for all of us to know. Because if the sample is not reaching to the lab in a right condition, you will not get anything out of that. Second question is coming when the counseling has to be done, right? So counseling is the most important thing, whether you do the genetic testing or not. but the patient has to be informed why you are required to get into this kind of thinking process. Because in this country, what we all do is Google, right? And suddenly we write genetic testing, we will come with the like NIPT, PGT, and all those things. They will pick up a few words, they will reach to the clinician. They don't get the clarity. So we need pre-counseling, which is very, very important. Why it is important? Because basis that you will take the like informed decision whether which test has to be prescribed, right? Whether it is going to be genetic screening, and then you have the like single gene specific disorders to be picked up. Those are the like very, very important things. Last thing which I will say, once everything has been done on the like NGS or in FISH, who's going to interpret that data? If you have the manual interpretation which is coming up, we have a limitation. So we need to really think about all those aspects, because at the end of the day, patient has to go through that stress, go through that pain. So pre-genetic counseling and post-genetic counseling is this super critical for every kind of test.
Yes, absolutely.
Add in this.
I,
So very important is definitely Amit is like right on this, but very important is mosaic. Do we give a percentage also? I mean, I see so many reports. Now, since we have a lab, we know the mosaicism is 15%, 20%, 25%, 30%, and we all know till 20 it's normal. So that all data is so important to counsel your patients, to give them evidence that yes, you can go ahead with this mosaic. So we got a paper published last year also with a mosaic embryo being transferred, and after 1 year the child became euploid. So it is auto-correctable also. So all mosaic embryos doesn't mean that you cannot transfer them. So sometimes it's so important that with people who just get mosaic embryos, you cannot just say that these are abnormal embryos.
So, Dr. Veena, once these patients are pregnant, especially when you have put a low mosaic embryo or you have had a pregnancy after PGTM. So, after pregnancy, what is the counseling, what you do, and what is the mandatory test or what you advise that they still need to go through this?
if we have transferred any embryos, even I would say that we should go for the testing like at 12 weeks, knuckle translucency and all, and further level 1, level 2, and blood levels also. So like that, I think we still need to do, in spite of we have transferred the best embryo, whatever is possible.
I would
And
like to
what
add
is your-
here, we should also do a prenatal diagnosis to confirm
Yes.
the chromosome abnormality.
Yes. So,
Because we just want to be confirmed, doubly sure at 11 weeks or 14 weeks whether the mosaic embryo which has been transferred is chromosomally normal or not. So this will give further peace of mind to the couple. So
Yes,
prenatal diagnosis either through CVS or amniocentesis is must.
So the bottom line is that the genetic counseling doesn't stop the moment they are pregnant. Still, you need an opinion. Still, you need the testing, especially when you are putting a mosaic embryo, and prenatal, antenatal testing for any disorders. Like you've tested for thalassemia, even if the embryo has come, normal, but you need to test that in the baby. So you have to offer that to the patient, whether it is chorion villus sampling or it is amniocentesis, but you need to go ahead and do that.
So just wanted to add here for counseling, we call it genetic counseling, but I think in IVF, hand holding that patient, right, who is going through that IVF journey is super critical. Because they will go through like so much of stress, and when it comes to the like genetic disorders which is going to be discussed with them, I think post, and then when they are going through the journey till the time baby is born, that counseling has to be there. Somebody has to be there with them in terms of making them understand what's going on, because nowadays people are kind of like they jump into the conclusion immediately. Oh, I have certain things, my parental like things are not fine and all those stuff. So somewhere going to that basics, and the way the clinicians are helping those patients nowadays, that is super critical. But I think clinicians are super busy. They have a lot of patients to be taken care of. So counseling needs to be done now.
So Dr.
Actually,
Gauri,
yeah, sorry.
yes, Dr. Beena, go ahead.
It's very important for clinician also to interpret the results and convey to the patient. Like, what does this result mean? And I have a question to the people who have lab. I have seen a patient like all the embryos were abnormal, and he wanted a recheck from some other lab, and 2 of the embryos were normal. How do you comment it?
So it happens with us also. So what we do is that definitely we do rebiopsy for those couples, and we then send it.
Rebiopsy or just getting it
No,
checked?
we actually do a rebiopsy because we all know that trophoectoderm biopsy definitely sometimes it's not 100%.
Yeah,
So
that
we
is
need
why.
to do a
Yeah. So that is
rebiopsy.
why validation of your lab, having huge volumes, having your country specific data is so mandatory. And also, we have to be judicious when we offer PGTA. See, we don't doubt PGT-M where we're looking at disease in the family. We don't doubt PGT-SR. But should we offer A to everyone? Because these are the nuances we are dealing with. Because after all, we are looking at maybe improving the efficiency of the process, but not a cumulative, live birth. But I think the way I interpret, if there are complex aneuploidies, then I don't doubt the report. I don't doubt the report. If they are complex, I will ignore and I will not transfer that embryo at all. Yes, Dr. Amit wanted to add on.
So just wanted to add here, you asked right now that should we do PGT to every patient, right? Again, it's something which we need to be very selective. When we need to do PGT, should we do it before an IPT? Should we do after an IPT? So what is going to be gold standard? Which are the patient should fall under that category? So I think in a basic sense, we all know if we are 35, less than 35, we will have 70 to 80% chances of getting the very nice eggs, right, which are going to have the abnormal chromosome. But once your age is going up, right, and you have the miscarriages, you have reimplant failures and all those stuff, genetic chromosomal abnormalities are going to happen. That's how is the biological clock which is clocking, right? So somewhere again it comes to the who are the targeted patients should fall under that category. If we are aware about that, because most of the time nowadays if you look at IVF clinics, they are popping up everywhere. Good, we have ART rule, but before that we were having so many IVF clinics. They just write test. So somewhere having that understanding, PGTA followed by NIPT or PGT followed by PGM or SR, what needs to be done, that is very, very important. And I think clinicians are going to play a very important role for that for the patient.
I think once the patient's result come, we should have a genetic counseling from a geneticist. And they should be able to guide properly rather than just clinician commenting on something.
And it is very important to get the patient evaluated by a geneticist before you send the sample also for PGTA or PGTM, because it's very important to find out the right variant. We have to get the panels made for PGTM. And there's so much of
Yes,
counseling
this
which
is-
a geneticist
yes.
needs to get it done.
Yes.
I mean, just a clinician, I have a geneticist, now I understand it's so important. When thalassemia couple come or SMA patients come, you need to find the right variant because you have to get the panel made for PGTM.
Yes, that's important. Even for PGT-SR, we cannot offer, because there have been cases, where there was this very minute deletion at the end of the chromosome, and our NGS platform will not be able to pick up. And we don't have fish, probes directed to that chromosome. And if you do a biopsy and send it to the lab, without knowing whether the analysis can be done or not, then you are answerable to the patient. You have done an invasive biopsy wherein you don't have the answer and the lab says sorry, we can't perform that. So it's important. Dr. Gauri, I want to know, we are doing this PGT, we are looking at PGTM. Now what is the cost, the counseling? How do you tell the patients what is the outcome we are looking at? Maybe we'll never have a normal euploid embryo. I mean, after all, it's a very long journey, and the last part is a baby in hand. So how do we assure that? How do we counsel? Is one IVF enough? They would need more cycles.
See, I think that is why it is very important that once you start a PGTA counseling, you should know to whom are you counseling also. You cannot pick up every patient. I mean, if a young patient is coming with blocked tubes and everything looks normal, I don't think so that we should even tell for PGTA, because according to ART rules, you can't even do counseling for such patients. So especially patients with recurrent abortions, patients with IVF failure, patients coming with low sperm count, where we actually counsel them, look, you have recurrent abortions or maybe you have an IVF failure. So you need to get your embryos screened for genetics, because this can be one of the reasons that you're not able to conceive. Now we have to tell them very clearly that once we try to send a minimum of 4 embryos. And we tell them it can be euploid, it can be mosaic, it can be aneuploid, or maybe all embryos are aneuploid, and we will have nothing to transfer. So that part of counseling is so important to them. And we also get a reason that why you're having a recurrent abortions, because all your embryos are aneuploid. So, how we then take this ahead, and absolutely, it's a journey for every patient that how we take this IVF cycle ahead. It's not easy, trust me, for us as a clinicians handling such patients when all embryos come aneuploid, and then you tell them, nothing is in hand.
I would like to add something to it. What generally I do is that once we have an elderly patient or maybe poor ovarian reserve, we do one cycle and we are sure we are not going to get enough embryos. Before doing genetic testing or PGT, we do another cycle and we try to collect couple of embryos. Once we have 3, 4 at least embryos, then we send, because we are sure all of them are not going to come normal and they don't have a chance to conceive because the age is advancing. So it is better to take that particular moment, the best embryos and the best number of embryos, so that we can even implant second time if they fail. So I would like to do 2 or 3 cycles before I send it. For all embryos I send together to give a better option.
So more challenge what we face as clinician is that when we are doing PGT-M, because on an average maybe 1 and 4 embryos could be normal. If I'm looking at PGT-M with HLA, it's huge number of embryos. So by and large, we are targeting at 6 or maybe 8 blastocysts in order to find maybe one absolutely normal, maybe 1 or 2 carriers. But in order to achieve these many number of embryos, maybe we need 2 cycles of IVF. I've had a case of cardiomyopathy where I had to do 4 aspirations in order to obtain, because these women could be having poor ovarian reserve. So it sounds rosy, but achieving that could be difficult. So as a lab, when will you be happy when I send you an embryo and you will say, or what is the DNA loss? What are the challenges what you come across?
So we don't have lab in India, and I'll just touch upon what are the challenges we are facing. So we believe on the consolidation. So we have the reference lab in UK and US. So all our samples are going out. So now the regulations are becoming so tight, right? Sending a sample outside is also very challenging. So logistics. Second thing, when embryo biopsy is happening, the one thing which is coming into all the patient's mind and everybody, sex determination, which is prohibited. It is very important to understand that biopsy is not for the sex determination. Third thing, what is coming, how the sample is being transported. So it's end to end, like whether you are transferring in India or you are sending it to outside India, the transportation, the logistics is super critical. And before that, the person who's doing the biopsy, at what time, what day the biopsy is being done, which cell is being picked up, those are very important things. Then when it goes to the lab, we also keep a balance, like one sample, because it's very precious for the clinician, it's very precious for the patient. How can we keep the backup sample? So if something goes wrong in terms of doing amplification, something goes wrong in terms of handling those kind of biopsies, we have some backup. Those are the things what we are doing. Another thing what we have implemented, and it is also very important, sometimes what happens, you have the long transportation time, and you consider India also, you will have long transportation time. Can we have the amplification lab in one place? So you just get the biopsy, amplify, and then send it to the your reference center to do the NGS. I think that has given us the lot of good data, good analysis, because we have now the AMP lab in Japan. So first we do the amplification in that lab, and then we are sending sample to our reference lab to do the overall analysis. The another important aspect, once the amplification and NGS data is done, no technician is going to read that report. It goes to the genetic council. The main genetic team, they will read that, they will talk to the clinician, they will talk to everyone. First, the clinician has to go through that report, and then it will be translated to the patient what is going to happen. So these are the things which we have seen.
Ashish, I would need your comments.
So what Dr. Amit is saying, so before sending a sample to any lab, there has to be thorough validation, including for the embryologist, whether he is taking a right biopsy or not. And then a thorough validation of genetic test what lab are performing. So there is a complete set of validation report which has to be signed out by a medical director before test is being launched for the patient service. So all these problems are well taken care if the lab has done a thorough validation, including transportation, because logistic is definitely important. Ambologist who is going to take the sample and the lab who is going to perform the genetic test. So if there is a complete validation, so labs or hospitals or IVF clinic can ask for the validation summary or what is the cutoff for a mosaicism. So those kind of front information will give the confidence to the clinician with a lab and where they can confidently send their sample going forward. So that has to be done and that is being practiced in US, Europe, and I hope many labs in India are also doing that.
So, Dr. Ashish, you were talking about, we always say that PGT is invasive. So, what are your views? Because in India now, there are certain places where they are promoting non-invasive PGT. In my lab, the embryologists still do not, they feel that it's still not validated enough and we still haven't resorted to it. So, what's your say about
So
it?
I also agree with your lab view because non-invasive PGS is still not showing 100% concordance. The sensitivity, maximum sensitivity is 91.3% and specificity is 93.3%. So you can't rely unless until the diagnostic test, because it is a diagnostic, not a screening test. So unless until there is 100% sensitivity with these non-invasive things, so there are a lot of research which is in progress and a lot of data has to be come. So there are a couple of labs where lab specific papers are coming up, but we need publication all around the world, even from our country, which is very limited, where this kind of data is limited. And this is something of future. Right now, invasive PGS has some limitation, but this is well established for PGT SR and monogenic disorder. Aneuploidy in select, like Dr. Gauri was suggesting, in select group of patient, we can talk to them based on their clinical history or whatever they have, and then we can offer PGT-A in those group of
So,
patients.
Dr. Gauri, since you have your own in-house lab, what are your views? Have you tried non-invasive PGT, and what was the confirmatory report?
My lab team is definitely more comfortable with TE biopsies only. And we did NICS in few patients, but I think the DNA content is not very great to pick up the full data. So I think the machine is not able to read the full data with these biopsies, the new ones. But I'm sure with the new thing which is recently launched on the blastocele fluid, where they take out the blastocele fluid and they have DNA in it, which is the newest thing coming up, and they say that that can give better DNA. Definitely that's in research till yet, but they have said that this is gonna be better than TE biopsies. But still, we are using TE biopsies till now in the lab.
Yeah, I agree with
So,
Dr.
Dr.
Gauri
Amit wanted
because
to-
10% is quite a bit, 10% false positive or false negative is quite a bit.
So just going back to that invasive and non-invasive, I think technologies are going to get advanced. We will have new technologies coming up, but one thing will become is gold standard. So every new technology has to be compared with that gold standard. So far, the non-invasive technology has not reached to that correlation with the
To
gold
that
standard.
benchmark,
So
yes, absolutely.
somewhere I think we need to keep that in our mind. When the normal PCR was there, we used to say that's the gold standard. Then the real-time PCR has come. That has become that gold standard. Now NGS has come. So the correlation, what Dr. Ashish is saying, is the most important thing, and the data which is going to be produced globally. What we have seen non-invasive is not right now acceptable globally. So somewhere we need to think about that. Right now we need to believe on the PGT.
So now last two questions will come to, and then I think we'll wind up. One is cost. Cost implication is, I think, something very important. How do we make it more acceptable or accessible to even, see, we are sitting in metropolitan cities, we are looking at urban population, we are looking at population with higher per capita income, but how do we make it accessible, because the genetic disorders are in all the populations. So what are your views? We as clinicians, I don't know how much we'll be able to do it. Maybe the labs.
So, go ahead. So it's a cost is subjective, ma'am, and again we need to look at that what we are treating, right? So like one patient will go through the 2 cycles to get those embryos. few patients will just go for the like one cycle to get those embryos, what is required for the like overall testing. But how can we make it affordable? My point of view, consolidation has to happen. So these are the like sequences, right? And they are very kind of like highly expensive sequencers, and the technologies which are changing is very, very fast. So if your sequencer is not full, you are not going to optimize your test. So in my opinion, I think consolidation, reference lab, all the like IVF practitioners, they should samples to the like validated and accredited lab. Because those are the labs who can do the like advancement as soon as possible when the technology is being changed by the like different companies. So that is where. Second thing, can we offer the like comprehensive total package to the patient, where clinician is also looking at what is going to be my cost per cycle for that patient. That includes genetic testing, normal hormone testing, all those stuff. It is basically like if you say the cost will reduce by 50%, we have not reached to that volume in this country, because all patients are not going to get screened by the like NGS. So that's what is my view.
I would like to add in this. So I'm using Thermo Fisher. So Thermo guys, hi. So definitely, because we use a huge pool of embryos every month, these guys support us with the costing, and we are able to help our patients because we have in-house lab. So for us, the costing definitely is so like feasible for us that we are able to give it to even patients who are like normally they actually need it. So I'm really thankful to Thermo guys on this. But definitely, if we do a good research and we have something on our Indian database and we have panels for PGT here, we can definitely get down more on the costing in this.
So cost is going to go down over the period of time. So when you remember, the cost per embryo for PGTA was double the rate what is being offered now. So I'm sure with the time the sequencing reagents the cost will go down, and we are just waiting so that more and more patient can get benefited with this reduced cost. And I think the numbers are important. If there are quite numbers, these machines and reagents, and then more Indian patients can be benefited by these next generation technologies.
So unless it is universally the technology comes in the public sector, it will still remain in the private sector. In the private sector, the only way we can reduce that if we have high volumes sending to really standard labs, because if we have mushrooming of labs coming in, then the cost initially would be higher up, and that would increase the cost to the patient. So now we end with views from all the panelists that we are in precision medicine, we are already doing something. We have chat GPT. We want to type a letter, we don't want to remember good English, we'll do chat GPT. So how will artificial intelligence help us further in bringing more precision to reproductive medicine?
Yeah, so I think AI everywhere, right? So as a company, I come from Cooper Surgical. What I have seen in last 8 years in our company, we have got into the like PGT AI. That's basically having the like 1,000 embryos database, 500,000 sample tested database into our basically sequencer. On top of that, 10,000 basically biopsy done data. So what we are trying to do, we have created a software which is going to do the like automation, basically interpretation of your results. That has already been launched. So that's the one advancement what we have done. So NGS will do that, and after that the interpretation will be done by our AI software. So that is becoming very, very popular for all the clinician and all the like genetic technicians. The second thing what we are also trying to do with the AI, and some technology is going to get changed. We are talking about single gene sequencing. We all talk about that. I think all the like molecular biologists and genetic people are sitting here. We are also looking at like PTA technology, which is basically the like pre-identified templated amplification with the whole genome sequencing. So single cell is going to get sequenced for the like whole genome, and on top of that, AI is going to read the entire data to give you the like faster results. So those are the like things what we are trying to do with the AI. But the most important thing in getting that database, which is going to lead to the AI, is how much data you are storing. Right now, we are dependent upon the like US or Europe data. Do we have the Indian data on board? Answer is no. So the most important thing to collect the data, and the labs who are performing all the genetic testing now, it would be important for them to get into the collaboration where the data is going to be very specific for this country, and then that can be implemented with the AI solutions.
If you talk to like this, we must be having much more data than what foreign countries, but only thing is they're not registered with us.
So
That is
can
the
we-
biggest problem we
Yes.
people have.
Can we have
and they are
one
depending on us.
closing remark now? A very quick. We have 2.5 minutes, less than that.
So I just feel that definitely AI will bring and aid all doctors, geneticists, and embryologists, but I think they cannot replace us. So I think the most important thing today is if AI comes, take it as a help. I mean, they'll help you to diagnose, but you should have to see your embryo and see whether AI is giving you the right diagnosis or not. So I think AI completely cannot be left alone. So
Dr. Beena, your closing remark. and then Dr.
I'm
Ashish.
I'm sure I agree with the AI is going to make a revolution in this field also, because as we see, which we never imagined is happening. So even with AI, I'm sure we are going to have the best results.
Dr.
So
Ashish.
AI can play a huge role going forward because the amount of embryos labs are handling, if all those data is consolidated at one place, maybe at a government registry where that information can be used, and then embryo morphokinetics along with NGS and human intervention definitely has to be there, because without a human brain, I think AI tools may go haywire around, and with all these things in combination can definitely help in a better patient outcome. That's what I believe.
So thank you very much. PGT is here. It will remain. It will get even more evolved. Today in the morning, I heard a talk where they said that sperm freezing will become so easy that it will be freeze dried and then sent through your post mail. So I'm sure something will come in future where embryos with a template would be made even without doing a biopsy, and something would come up. So thank you very much. Thank you, Voice of Healthcare and the panelists, for such valuable information.
I'd like to thank the panelists for such an insightful discussion. I'd also like to thank Dr. Gupta for wonderfully leading this panel. Now I request Dr. Gupta to felicitate her co-panelists. Dr. Gauri Agarwal. Dr. Amit Bhatnagar. Dr. Beena Muktesh. Dr. Ashish Fauzdar. I'd also like to request Dr. Manisha Khurana to felicitate Dr. Shweta Mittal Gupta. Dr. Shweta Mittal Gupta. I now request all the panelists to come to the center of the stage for a group picture.